contact Jonna Hess at the state office, and she can give you her schedule for other squads that may be testing in your area, and those are open. Most people have no issues, and they're not full, so there's plenty of room in most of those locations. But she can put you in contact with their training officer, and you can get test dates, or if you need education, it's kind of an extra link there. But if you need testing, contact John Hess at the state office.
Okay, I apologize.
No, you were doing this a good job, and you were on a roll.
And just so everybody understands that process and how it's going to take place, there is an option with the company that the Office of EMS is going to use for testing to do online testing. It's cheap. It's relatively easy to become a testing site. I mean, there are parameters you have to meet, obviously, but it's much easier than using like a Pearson VUE and that kind of thing. But to do that process, it has to be bid out. So in the meantime, and correct me if I'm wrong, but in the meantime, we're working on getting the paper test back out to the training agencies that have agreements to administer those. So that may be a temporary fix, get those tests back out to those agencies, and then continue to work on the bid process and putting bid specs together, which will be a lengthy process to be able to get the online component of that together. Now, OEMS.
Okay. No new vacancies or new hires. We still have a vacant Office Assistant 3 position in the trauma unit. But the hiring freeze continues, as do other budgetary constraints related to travel and hospitality for meetings. We have an average of 20 investigations that come in on a monthly basis. 75% of those are completed in the same month. Some of those are simply referred back to the agency or regional medical director to review, and the others do require state investigations. We continue to have about 6,000 folks on the rosters, with 4,000 being active at any given time. As of the end of July, we had about 38,000 runs, which is about our average for the past 12 months. For fiscal year 2017, we had 534,893 runs. But of course, with the EPCRs continuing to come in, that can fluctuate for probably the next 6 months or so. We were seeing a 60-40 split, 60% BLS, 40% ALS. Now what we're seeing is closer to 47% BLS, 25% ALS, 1% Aeromed, and 27% unknown. And you'll see in other areas, as I report later, we need to do a little bit better job with our documentation, because we do have a lot of unknowns. Our largest age group being transported is the 50 to 90-year-olds. So you'll see an uptick in the curve at the older end of the scale. But for children age 0 to 18, West Virginia is pretty consistent with the rest of the nation, with 5% of transports being for children. And we are seeing from 0 to 1 and the 3 to 18, so the curve looks more like a U. Naloxone administrations for 2017. Now these are January to December numbers. 3,966 naloxone administrations so far. For 2016, we had 5,901. Related to naloxone administrations, we're working with a number of partners on opioid overdose prevention strategies. We're working with Violence and Injury Prevention Program, the West Virginia University Injury Control Research Center, the Bureau for Behavioral Health and Health Facilities, and the state police. We applied for a SAMHSA First Responder Cooperative Agreement that would provide naloxone for EMS agencies in selected high-risk communities, and it would also provide funds for those communities to implement an intervention program, so that we could have potentially several pilot projects over the state related to EMS initiating those intervention strategies. We've not heard about the notice of award on that as of yet, and I'll keep you all posted. We're also facilitating a multidisciplinary work group that's investigating the overdose incident that occurred in Mason County in April of 2017. And DHHR, the Bureau for Public Health, are implementing an Office of Drug Control Policy. Jim Johnson has been named the director of that office, and he will be working to supplement his staff. We anticipate the tobacco prevention program lost all of their federal funding, so we anticipate some of those folks will find a new home there at the Office of Drug Control Policy. Our state average response time remains about 2 hours. 1,182 vehicles are permitted, and we're now back to 200 agencies. We are averaging consistently 4,500 to 5,000 trauma runs in any given month. Again, the most prevalent injury being fall, followed by motor vehicle accidents and unknowns. We have finally gotten the permanent contract for the CIS, and it was awarded to UNC PIC again, so we will be able to move forward on a number of initiatives in improving the operations of that system. Yesterday, I did send out via CIS message to all EMS personnel, please do not self-deploy for efforts related to Harvey or Irma. Irma has been downgraded to this point to a tropical storm. It's anticipated to leave our area Thursday and Friday. There is Hurricane Jose that's out there in the Atlantic right now brewing around. He is weakening and not anticipated to have any U.S. mainland impact. But please do not self-deploy. We have been asked by the Department of Homeland Security and the SEMSO to remind folks that we need to have those efforts coordinated and through appropriate channels. The Center for Threat Preparedness and their healthcare preparedness program has a federal grant that has a coalition focus. I know a number of EMS agencies have participated in regional hospital exercises in past years. You will see those hospital exercises changing. The requirement has increased for those exercises to be on an annual basis, and at least one hospital in each region will have to evacuate. So yes, they will be calling upon EMS to participate in those tabletop exercises initially. So you may be able to participate via phone or just have one person there for that component of the tabletop. And we'll talk more about that in October when we have our annual agency official rep meeting. NHTSA, the Office of EMS, and the SEMSO are working to update their emergency vehicle operators course, so when that's completed, I'll share that with the group. Our State Trauma Advisory Council has a new chair that will be taking over in October. They just met August, and we talked with them about the National Trauma Care System, integrating military and civilian trauma systems to achieve zero preventable deaths after injury, which was put out by the National Academies of Science, Engineering, and Medicine. And this is a paper and a webinar trying to have a national trauma system. So we'll be working toward that with that group over the next several years. The secretaries for DHHR and DMAPS are working for the transfer of the communications unit from OEMS to DMAPS. The staff have been transferred. However, we're still working on the transfer of all the equipment, funding, tower leases, insurance, and all of that. with the budget situation, and some issues that were unforeseen with the communications transfer, we were not able to provide funding to TSN. So OEMS has absorbed all of the functions that TSN was previously providing. We had our first stroke advisory council meeting in July. We have 13 members appointed and 12 of those members accepted. Representatives from WVU, St. Mary's, Rome General, the American Heart Association. We reviewed the proposed stroke rule. That stroke rule, the comments and responses are posted to the Secretary of State website if you're interested in looking at that. And our next meeting of the Stroke Advisory Council will be September 28th. And OAMS did participate in the planning and response for the Boy Scout Jamboree. There were nearly, is Shane still here? 40,000 scouts, 500 scouts from 81 different countries. Public health screened 614 buses. 571 of those had no symptoms, but there were 3 potential outbreaks. 2 were ruled out for the nausea and vomiting that was travel associated, and 1 was an isolated outbreak for strep throat. And of course, as you can imagine, with trail bikes and skateboards, a lot of the responses were related to broken bones, cuts and bruises, bug bites, burns. Fortunately for this event, we did not have any deaths like we did experience in the first Jamboree, so we were thankful for that. And I think that's all. Hmm? Oh, yes. Our annual, I've mentioned it briefly while I was talking. Our annual official rep meeting will be in October. We will be doing that in conjunction with the Bureau for Medical Services. They will be doing a training at that time for EMS. They are looking at doing a pilot project. It's the first of its kind in the country that will provide for reimbursement for the administration of naloxone. So we look forward to getting information out about that. It will be here, and we haven't worked out the date yet for that. No date. Any questions?
Anybody have anything for the Office of EMS? Okay, let me get a general consensus from the board. Under special reports, we have CCT, mobile integrated healthcare. That's in a special interest committee of its own now. Do we really have a need to have that separate? Okay, medical command. Right here. Greg, got anything?
Nothing.
Anything happening?
Same old, same old.
Nothing ever
Aeromedical.
happens with the medical command.
Aeromedical.
I have one thing to report. Yesterday morning at 0800, we opened our 10th base of operations in Moundsville, West Virginia in support of WVU Medicine. And that base is fully staffed with instrument equipped and twin engine aircraft, blood and plasma and antibiotics as well. Thank you.
All right, we're gonna backtrack just a second back to OEMS. Vicki?
Yeah, I'm just gonna let everyone know, if you haven't checked your CIS or your emails, we sent out information a few weeks ago on 5 stable trainings, the post-resuscitation pre-transport. There's gonna be one held in Parkersburg, Fairmont, the Mining Academy in Beckley, one at Kanawha County, and one at Wheeling Jesuit University. They are free. We've got funding from HPP to provide those. So it's posted on our website, and it also went out in CIS.
Is it one in Martinsburg still active?
That was canceled due to lack of participation.
All right, is there any other old business that we haven't covered in committee? Anybody has anything? Okay, I open the floor for new business. And to start out new business, we have a guest to discuss the National EMS Advisory Council.
Hello guys of the audience and council. For those of you who don't know me, which is probably most of you because I'm fairly new to these rooms, my name is Mike Thomas. I'm the Director of Safety and Risk Management for Care Ambulance Service. Recently in last month, I went to Washington, D.C. and attended the National EMS Advisory Council. This was their last session for these members, so they will be changing after this one. So a lot of these issues could have come up before I got there. This is my first meeting there. I went there for several topics. For Care and Melissa thought it would be a good idea that I report back to you, so I will keep this succinct and try to move things along. For the Director of National EMS, Dr. John Cromer, he reported that this nomenclature issue that I want to touch on briefly, it may have been going on for a long time now. Jerry and I were just speaking about it. He was wondering why they didn't bring it up years ago. But apparently the cabinet, the colleagues, the team of the Surgeon General are not happy with calling this profession paramedicine at all. They want to be called EMS providers. With regard to community paramedicine where they are involved, they don't like the term paramedicine or paramedic because, you know, the prefix para means equivalent to, and they feel like it's equivalent to what they do. So they are trying to make it to where we are called just simply EMTs at a level or EMS providers fully, and that's it. No paramedicine, anything like that. Everybody in the room was very upset with this. There were several arguments about it. I'm just the messenger, so please don't crucify me after this. So this is just what they were discussing, and obviously the EMSAC committee voted to not even entertain this idea at this time to change the name for community paramedicine as it stands. I mean, it's already been named and things like that. So that was a hot button issue up there. I'm not going to talk about it too much. You guys can read about it. There's a lot of research out there about it. The second thing basically that they said is coming, and again, all these things that I talk about, these aren't things that have to do with right now today, but it's something that you guys might want to see is coming down the road. These same people, as they call them, top docs in Washington, D.C., they're also adamant that endotracheal intubation be removed completely from the EMS scope of practice altogether. They said that this has been coming for years. I'm not sure. I haven't heard about it until just now. Paul has. He discussed it with me, but they said to get ready for that Washington's going to make a big push for that to be taken out of the EMS scope of practice. Basically, what I'm here to talk about is fatigue in EMS. That's what I'm very interested in and have been since the creation of this committee, since the inception of the EMS Fatigue Committee. It was actually created back in 2012, but their first set of meetings were back in 2016 as I attended them. And Dr. Daniel Patterson, who, if any of you are familiar with him, he's kind of the standard when it comes to fatigue in EMS. The committee has come up with 7 PICO questions. And if you're not familiar with what PICO is, basically P is for problem, I is for intervention, C is for comparison, and O is for outcome interest. it's been a difficult process because fatigue in EMS is very limited with regard to scholarly articles or essays. Being the director of safety at GenCare, I have a lot of the guys who've been here 10 and 20 years, and people like this tell me stories about fatigue that kind of made my hair stand up on the back of my neck, that they would work so many consecutive hours. I'm sure a lot of you all have the same stories, I would say. And now they're trying to do away with that. This has become a big time issue, as you've probably seen on the news and things like that. The 7 PICO questions that they've come up with, and the final results will be out in December, are as follows. Number 1, and for some reason they have these answers, like the recommendations from the EMS fatigue committee backwards. So I'm going to read 1 through 7 and then answer them 7 through 1. I'm not sure why they have that, but that's the way it is. 1, are there reliable and valid instruments for measuring fatigue among EMS personnel? Number 2, in EMS personnel, do shift scheduling interventions mitigate fatigue-related risks, and or improve sleep? Number 3, in EMS personnel, does the worker's use of fatigue countermeasures mitigate fatigue-related risks, and or improve sleep? Number 4, in EMS personnel, does the use of sleep or rest strategies and or interventions mitigate fatigue-related risks, and or improve sleep? Number 5, in EMS personnel, does fatigue training and education mitigate fatigue-related risks, and or improve sleep? Number 6, in EMS personnel, does the implementation of model-based fatigue risk management mitigate fatigue, and the following that I've mentioned 5 previous times? Number 7, in EMS personnel, do task load interventions mitigate those items too? Fatigue-related risk, and or improve sleep. The recommendations are, and I'll read them back off. The last question, in EMS personnel, do task load interventions mitigate these things? There is no recommendation at this time. The confidence in effect estimates is insufficient to make a recommendation. 6, in EMS personnel, does implementation of model-based fatigue risk management mitigate those things? No recommendation, same reason. Number 5, in EMS personnel, does fatigue training and education mitigate fatigue-related risks, and or improve sleep? They recommend that EMS personnel receive education and training to mitigate fatigue and fatigue-related risk. Number 4, in EMS personnel, does the use of sleep or rest strategies and or interventions mitigate fatigue-related risks, and or sleep? They recommend that the EMS personnel have the opportunity to nap while on duty, on station, to mitigate fatigue. What was surprising to the NEMSAC as far as this one is Dr. Patterson goes all around the country doing surveys, and some of you still may do it, and I'm not judging. I'm just telling you that the NEMSAC was kind of appalled that there are still agencies out there that will fire you if you sleep while on duty on the station. They were kind of concerned with that, but he said there were a lot more than you would believe that no longer or never have allowed people to sleep on station while on duty. Number 3, in EMS personnel, does the worker's use of fatigue countermeasures mitigate fatigue-related risk and or improve sleep? The EMS fatigue committee recommend that EMS workers have access to caffeine as a fatigue countermeasure. So basically, they're saying that they recommend to put a coffee pot on the station.
Recommend they take it away and have it.
Number 2, in EMS personnel, do shift scheduling interventions mitigate fatigue-related risk, and or improve sleep? The committee recommends that EMS personnel work shifts shorter than 24 hours in duration. A lot of people are guilty of the opposite of that up there as well. The panel does not have any recommendation regarding 8-hour versus 12-hour shifts or other shift comparisons that are less than 24 hours. So they just say basically they recommend working less than 24 hours consecutively. Are there reliable and valid instruments for measuring fatigue among EMS personnel? The committee recommends that fatigue sleepiness survey instruments to measure and monitor fatigue in the EMS personnel. They recommend that. It's a strong recommendation. And by fatigue, sleeping, and survey instruments, you can go on emsfatigue.org and download. There's resources, a list, they're probably 3 pages long of different surveys that you can put out there to your crews and let them take the survey and turn it back in. It is anonymous, of course, and it's a very good tool actually to do that. So that's basically, in a nutshell, the fatigue and EMS. The next thing I want to talk, not to go back to the nomenclature, but really a humorous portion there was the top docs, as they call them. They wanted to know in community paramedics and mobile integrated healthcare what their titles would be. And their example was, what will the titles be for doctors, nurses, respiratory therapists, and et cetera in your community paramedicine protocol? And all these brains and knowledgeable people came up with doctors, nurses, and respiratory therapists. So that was pretty humorous as they were moving along. Lights and sirens, just to finish up. The lights and sirens, they predict in 10 years, lights and sirens will be completely obsolete and done away with in the entire country. As of right now, I'm not sure. I find that hard to believe, but you know, we'll see. Some people have already done away with it. The Dr. Jeff Clausen, who is known as the father of modern emergency dispatch and was there, says that going lights and sirens typically doesn't save much time, maybe less than a minute. And their fire department, that he's the director of dispatch there at their fire department in Utah, they no longer respond lights and sirens to any MBA unless the caller or whoever reports the MBA says it was at a high rate of speed. Unless that comes in like that, they no longer respond lights and sirens to those type of calls. He actually said there that you can't actually prove from the public safety and medical literature that lights and sirens save more people than they kill. And this is just a quote from him, just right from his mouth. Matter of fact, he can make the case that they kill more people than they save. In Hennepin County, Minnesota, ambulances respond to lights and sirens on 81,000 calls total, and only about 7% of those, which was 5,700, used lights and sirens on the way to the hospital. Alana Health Emergency Medical Services in Minnesota, where Brian LaCroix is the director, uses the following acceptable lights and sirens guidelines. Trauma with non-compressible hemorrhage, amputations, STEMI, CVA, head trauma, unmanaged airway, complicated childbirth. They claim that if these are not the situation, then lights and sirens should not be utilized. Code 3. There was a lot of debate on this lights and sirens deal. Through my research and speaking with some of these guys, they're emphatic. It's a strong political issue that will take time to develop if organizations are trying to get on the same page with their EOCs or 911 centers on these call guidelines. Like I said, in 10 years, they say lights and sirens will be completely obsolete. And that is pretty much, in a nutshell, all I have to move this along. So thank you.
Mike, thanks a lot, I appreciate that. And what you solidified is that I never need to attend that.
Just the way they wrote it on the team.
Does anybody have any other new business?
Question, the military medics, are they allowed to come in and start practicing, or do they have to take the paramedic program now?
Challenge National Registry. Challenge National Registry, then they can apply for the state.
Okay,
Some of them have national registry, we might have to change it.
that's what I wanted, if they hadn't taken anything else.
They still have to do the MCI, the hazmat.
Back to MCI and hazmat and all the rest.
Yeah,
Get
the
their ALS
standard
protocol.
stuff.
The Army and the Navy now require all their field personnel to go through the National Registry course. The Air Force still does not require that, so.
The Air Force doesn't?
That's correct. They have their own universities that they use for credits for that. But everybody, Army and Navy goes through through national registry.
Does everyone in Army Navy test National Registry, and do they have to pass, or do you?
They are required to test and pass national registry. That's how they're, when they do their combat medic program or their Navy corpsman programs, they have to have that now. They just started in 2013, so it's still relatively new to them.
You have anything, Dr. Wells? Ed, anything Department of Education wise?
Not at this time.
No more new business. Anybody have anything out there?
I have a couple of questions about research. Do you have a packet that's put together for the recertification of ACTs? What the requirements are for research?
Yeah, it's on.
Is it on? I haven't seen the research packet for ACTs, unless I'm missing it on the
There's a
website.
research policy out there that's got.
What the same thing as what we have for the medics and the EMTs? What they have to, what their requirements are?
Yeah, and it's got the paperwork attached to it there.
Okay, I didn't see it. Okay.
Yeah,
My-
it's on OEMS website and EMSAC website.
And I had one other question. On the new proposed recertification policies for paramedics, I know most of it's going by what National Registry requires, right?
Right.
Other than, let's say you take a 16-hour PHLS class, and only so many hours of that counts towards your, like, trauma or whatever. Those excess hours used to roll over, are they still going to roll over as your extra continuing education hours? Because I was told they were not, or I understood it that they wouldn't.
All right, let me look at it. A second.
Because if you sit in a 16-hour class, you should get 16 hours credit. Should.
The problem is, okay, people were turning in hours for those classes and trying to roll hours over for classes that aren't that long. And that's why we had to say, okay, there's got to be some kind of limit here. So, you're talking about the proposed policy, right? The one that's out there now for comment?
Yes, yes.
Okay. So for a medic, the only additional CE hours you would need, other than what's required, is 8 additional hours in something.
Okay.
Okay, so you'll have to take PALS, PEP, or an OEMS approved equivalent twice during the 4-year
Right.
period. You'll have to take ACLS or equivalent, and ITLS, PHTLS, or an approved equivalent. Taking those twice, you can get 16 hours out of each. So they're giving you 8 hours per refresher.
Okay.
But like I said, the way it's written now is you only have to acquire 8 additional hours. So most
Okay.
people will have that.
I just was misunderstanding. All right, thank you.
Chairman, let's back up a second. Did you want me to discuss or mention the name change, or wait until the next meeting when it's more official?
That's probably not a bad idea. I can go ahead and do it.
You know, if everybody can hear me. As most of you know, the legislature this year did away with, did away with RESAs. Public service training, I don't even know if this thing's on.
It's
No,
on.
that's good. Okay. Public service training,
You look good, Holden.
okay. Is going to, and always was funded out of the State Department of Education, my office. So the dissolution of RESAs has really nothing to do with public service training. It will continue. I know there was a lot of, rumor and innuendo this year about what's going to happen with, with the RESAs and with the 6 areas that we have in public service training. Just wanted to assure everyone that that is going to continue. They may not be in their current locations, and there was a name change, because since recess are going away officially as of June 30th of next year, we're kind of being proactive with it. So instead of RESA 1, instead of all the RESAs, we took the RESA name out, and it's now West Virginia Public Service Training Beckley for RESA 1, West Virginia Public Service Training Clarksburg instead of RESA 7, etc. That's the only difference. That'll be reflected as such in the future in OEMS on the website and in their publications, as well as our own departments. So that's just kind of an informational.
There's also there's a website now, a statewide website, which is wvpst.org. And the idea is that will grow. The public service trainings have bought a database that we've offered to share with WVU Fire Science as well. And that will be part of that website that people will be able to go in and pull their own certificates and pull classes that they've taken anywhere in the state, any of the RESAs. They'll all be in one location. So you can go in and search for your name and pull up all of your stuff right there. So, you know, that's all things that are in the works that are actually pretty well into the works right now, which will make it a lot nicer for everybody. Okay, last call. Any other new business?
We're going around the table. Oh, that's all point. When you do something like that.
Yes.
Oh, is there going to be any type of outline or PowerPoints for the module training?
Yes. The module training, actually, we appointed committees today. The EMT is well on its way to being complete.
Okay.
Karen's going to work on and I showed an example of that earlier committee. There will be one set of slides, and there's going to be an instructor module with that to go with those slides. Karen's going to do the EMR, and then we have a committee working on the paramedic as well. So that will all be done. You're welcome to get on one of those and help if you want. All right. And those, you know, obviously as we go on, those will need to be updated and changed and kept up with the times, but at least we'll have one product that we'll be able to go in and amend and continue to do that with. And probably what's going to happen, once those things are ready to roll out, and this all has to happen quickly. I want everybody to grasp how fast that's got to happen to get something implemented January 1. We're probably going to have some rollouts as well on, you know, how do we teach this? You know, not that we don't know how to teach, but different concept, different process. How do we enter the CIS, and how do we go out and teach this in modular design? So we'll have to work out all those kinks as well. Karen's retired now. We can send her around to roll out. Okay. All right. Let's go around the room. Go to the order. Start with you, ma'am.
So I just wanted to share a study that we're going to be doing, and I want everybody to hear this because we have already had a couple of meetings, and somehow or other that we met on a topic came out, and we've been getting some phone calls wondering if we're going to introduce legislation. So let me tell you what we're doing. We are meeting with currently the Office of OEMS, Kanawha County Ambulance, Thomas Memorial Hospital, the Hospital Association, and PEIA. And we're discussing the problem of the overuse of an emergency department and how that pertains to several issues. One, what is it that stands in the way from an ambulance going someplace other than an emergency department? And all that goes with that. I mean, is it even possible? What would a protocol look like for such a thing? Are there legal and liability issues involved in that? We know there's payment problems with those components. And so we are doing a limited study with those interested parties, and we'll probably ask others if they'd like to participate. All we're doing is gathering data. We're not actually redirecting any patients anywhere. Oh, by the way, part of it is where else would you go, and would they be willing to accept them? So we have several primary care clinics that are also willing to participate in our pilot study. No patient at all, 0, are actually going to be redirected. It's strictly going to be, we're putting it together now. We think it's actually just going to be a card that starts in the ambulance and ends in the emergency department. The goal is to collect data for probably 2 to 3 months just to get the sense of, and I really can't tell you any more because we haven't met yet to put the next stage together. But the concept would be there'd be some type of patient that an ambulance would arrive upon, through some evaluation would say, that does not need to go to an emergency department. We can go to, and then plug something in, MedExpress, a primary care clinic, a hospital that has a clinic right next to their emergency department, but not the emergency department. And really want to evaluate that from a medical safety perspective is our goal. How many times would we get that correct versus wrong if we were to do that? So anyway, the reason I want to bring it up is because we've met a few times to discuss this. It's just a conversation, and we're going to collect data. And I've gotten a few phone calls from other parts of the state asking me what this legislation was going to be that we were introducing to make that happen. And that's not at all even the intent. Even if the study was positive, we still wouldn't be looking to run off and do something like that. There's a lot of things in motion on such a topic like this. For example, should we take this to the next level where we actually pilot it, one of the conditions of the pilot would be that the ambulance would have to be reimbursed at the identical rate as going to an emergency department. And so, because there can't be winners and losers in this process, crystal clear for that. So anyway, if you hear something and it sounds different than I just said, please feel free to contact me, or if someone approaches you and asks you what's going on, you can tell them nothing's going on. We're just really just trying to collect data and just looking at, we can't, the way we're viewing this is we can't keep doing the same thing over and over and over again. And, you know, as hospitals, we recognize we're a great part of the problem because we spent decades advertising, come to our emergency room. In fact, we still have a few places in the state that have signs up that says, 10-minute wait, come on in. We've done that very well, and we've driven into everybody's head 911 really well, and so I think all these decades later, we've arrived at a spot that should have been predictable. We certainly have squads waiting in the emergency department, hours in some cases, waiting to get a patient off a gurney and into a bed. And so it's a complex problem. We just don't want to stare at it and say, well, it's world peace, let somebody else do it. We would like to at least start to take some baby steps in looking at just how big a problem it could be. So I wanted you all to hear that from me, and if you hear anything contrary to that, and Dr. Mills and Melissa are sitting at the table listening to make sure we're not doing anything that we should not be doing. So just feel free to ask or email me or whatever.
Real briefly, when I was young, I don't think you guys heard of a book called 1984. Big Brother's Watching You. I've just been thinking about this, and I'm just throwing it out there in this day and age. And the EMS personnel in the EMS world, been on a few calls lately, And you look up and you look someone across the street and they have their phone and they're watching it and they move. So honestly, my thinking is they're taping, they're videotaping, recording your actions, your moves, car wreck scene or whatever. Thinking that we need to really watch and be careful, be professional, act like we know what we're doing. Be open, act like we're doing, because we're really being watched, and then people are video recording. So it's happened several times to me. I've seen it just like watching me talk to the patient, moving the patient, how I'm lifting the patient, and so forth. I think it's something to be cautious, and we really need to be professional and do the best we can, because we're really being watched.
Cops especially like that.
That's what gets us in trouble.
Don't like
The
it.
cops with their daggone cameras on right here, they jump up in the back of your ambulance and everything. Yes.
If I could comment today on what you just said, we actually had a crew on an overdose call that was being broadcast on Facebook Live, and we didn't have any idea about it. The guy that overdosed was broadcasting.
That happens all the time.
And there's no way to stop it.
On that note, and Dr. Mills, you might have some information about the $6.5 billion about getting the AT&T FirstNet network up, where police, fire, and EMS would have their own, and basically we could look at the cell phones and what the police are seeing in the fire department. I know Governor Justice approved that, and supposedly, if it works the way it does on the website, they're going to put 8,000 new towers up somehow in West Virginia, and that everywhere we would have a 4G AT&T network that would be absolutely secure. And for EMS, that means that the police officers are there, you could actually see their video cameras and find out the bad guy is down or not, right? And respond. Fire department same way. But then more, if you look at community paramedicine or the next level of telecommunication, with stroke, et cetera, anyone with a cell phone theoretically could then have a secure line to go back with physicians or MCPs or community paramedics or strokes. Have you heard anything from the OMS side? I mean, it sounds almost too good to be true, and I know that we're part of that, infrastructure build out, but has the OMS office gotten any information other than what was kind of released on the news? I went on the news and said, oh yeah, this is going to be great, but whether it really will come through, All I know is that the Board of Medicine is